Yeah, I think it'd be good. There's lots of people turning up now in the chat, so that's great. So welcome everybody to Thursday's Devon AHP Week midday celebrations and sharing. So we've just been asking everybody that's joining to introduce themselves via the chat bar. Obviously, there's some general housekeeping today, which is being shared on a central slide, just around making sure that you're keeping your mics mute, that you put your hands up for any questions or anything. And also just to say the session's being recorded and will be uploaded on YouTube for access later on. So I'd like to welcome everybody and also welcome Vicky Goodwin, who's going to kick off the presentations with us with a fantastically titled Tales of the Unexpected. So Vicky, I'll hand over to you. Thank you.
Thanks, Donna. Thanks everybody for coming to listen today. So I'm Vicky. I'm a community physio by background, and I work at the University of Exeter, and I'm Professor of Ageing and Rehabilitation. And Abby Hall asked me to come and talk to you today about my career because she said it's interesting. I'm not necessarily sure that it's that interesting, but what I'm going to do for the next 10 minutes is just give you a few nuggets of things that might sort of share with you about my experiences of becoming an academic that may reflect your own experiences of getting involved in research, but also might be relevant for those of you working in clinical practice. So this is the tales of the unexpected of how I came to be here talking to you today, because certainly this isn't where I expected to be in my career. It wasn't a master plan, and certainly I didn't even start out thinking that I was ever going to be a physio even. I went to a comprehensive school in rural Lancashire, and very few people went on to study A-levels, and even fewer went on to university. And actually, I started out after my A-levels, I wanted to do electronic engineering, and I realised that it wasn't for me, and I abandoned all interest in academia after my A-levels and actually got a job as a physio helper. And for those of you that are old enough to remember, this is what physio before they were assistants and before they were aides, we were known as helpers. Applied to study physio, didn't get in, went to night school, did some more A-levels, and finally qualified at the age of 26 as a physio. Trying to make sure my screen changes. So, as I said, I never intended to be an academic, and actually it all started with a problem, as should all research start with a problem. I talk to many people who are interested in getting involved in research, and they come up with a solution. Oh, I want my patients to have this intervention or this treatment or this bit of tech. And I go to them, but what problem are you trying to solve with all of that? So it's really important we always start with the problem. And my whole academic career started as a problem. And I was the falls lead in the local trust down in South Devon. I was based in Newton Abbot. And I shared an office with the Parkinson's nurse, and we were chatting one day, and she said to me, oh, why won't any of your physio colleagues let my people with Parkinson's attend the falls prevention exercise classes? And I'm like, oh, I don't know. So I went and asked them, and they said, well, they've got Parkinson's. Of course they fall. What do you expect us to do about it? And that's a bit of a red rag to the bull for me. So off I went to have a look at the literature. And what I found was that around a third of older people are known to fall each year, but actually it's 2/3 of people with Parkinson's will fall each year, and they fall even more frequently than older people. So we definitely had a problem. But in terms of the solutions in the literature, there were no interventions of any sort actually looking to address preventing falls in Parkinson's. It just didn't exist. So actually, my physio colleagues saying, well, what do you expect us to do about it? They were probably right. So that started off my career, and my boss in public health sort of got me having a conversation with the new medical school that had just started in Exeter, and they said, oh, you should do a PhD on looking at this. And I'm like, a PhD, really? So I put in a funding application, wasn't successful, and I thought, oh, actually maybe this is quite interesting. So I got some other funding, some regional funding, to do a feasibility study to look at exercise to prevent falls in Parkinson's. And 3 years later, I went back to the National Institute of Health Research, and actually I was awarded a PhD fellowship back in 2006, 3 years after my first attempt. And this was the start of my clinical career and a desire to make things better for patients, because that's what I do as an academic. What's important to me is not the research, it's about, can I help my patients improve their outcomes? But research is team science. It's not something that we do on our own. I know some people think that we're up in our ivory towers playing with our pet projects, but actually it's all about teamwork, and working with older people in clinical practice is no different. It involves multi-professional teams, people from health and social care, from primary care, secondary care, community services, mental health services. It's all part of the same. So I'm used to working in a team. But actually, in terms of building networks, it wasn't something I ever thought I could do. I wasn't very confident at the time. And actually, even before I went into research, I wanted to sort of link with other people, and actually joined Agile, which is the professional network for physios working with older people. Just as a member, and then I became the regional rep, and then I became the research officer, and somehow I ended up as chair of this national group that then linked me in with the British Geriatric Society, who's a medical profession. And at the time, they weren't really engaging with AHPs at all. And that's something that I've been able to change, that actually now 15% of their membership are nurses and AHPs. And that's something that I was badgering them about sort of nearly 20 years ago. So I've been able to have influence much wider than I thought I could get. But what all these networks, and you can see here some of the networks that I've been involved in. I've sat on our national council, I've done stuff for NICE, but actually I've developed collaborations all over the world. And I don't know quite how that happened, but I think it's all started by me just sort of putting my head above the parapet and saying, oh, I could be regional representative for the Southwest for Agile. And that just led on to me developing networks, developing collaboration, developing leadership, which I think has really helped me in my academic career, because sometimes you've got to put your head above the parapet and put yourself out there and ask people a question, and they might ignore you. Or they might say no. They might come up to you, but they might come up to you at a conference and say, start having this random conversation. And then you get involved in a multi-million-pound study just from a conversation that you had at a conference. So making the most of any opportunities to engage with other people within your profession, within your organization, outside of your profession, other groups in other countries actually can have a real impact, not just on my career, but hopefully on patient outcomes as well. So I'd really encourage you to get out there in your clinical roles, in your academic roles, and really sort of build those networks that you're part of, because you never know what it might lead on to. But you'd think from all of that, I'm just a yes person. And actually, I used to be, but actually I try to say no a lot more. And I came across this slide on Twitter quite recently on practical tools to help you saying no. And I've actually shared it with a lot of people who say they now put this up on their office. And actually, what sort of things should we be saying yes to? Well, actually, things that are interesting, things that are working with nice and interesting people. Because actually, what you don't want to do is a dull thing with dull and uninteresting people, and there's no one benefits from the end at the end result. So really think about this when you're thinking about things that you might want to do or opportunities that come up. Actually, do you have fear of missing out? But actually, maybe you should replace it with joy of missing out. And I didn't realize this until recently, that I should have been going to a 3-day event, in-person event earlier this year, and I couldn't go because my husband had COVID. And I was thinking, oh no, it's such a shame I won't get to go to that. But actually, it was great. I ended up with 3 days that I didn't know I had. So I had definite joy of missing out from going to that. So these things are really important for us to think about in our career, because you can't take on new things. And if I do take on a new opportunity, something else has to go. So recently, been appointed to a national funding panel that will take up a considerable amount of my time. but I already said sit on a national funding panel, but it's much smaller in its remit. So I'm going to have to step back from that because I haven't got the capacity to do both, because one, my husband would divorce me. But it's really important to think about those non-work things that are important. They're the things that are important to us. We don't live to work, we work to live, and we should keep that in the back of our minds when we're doing things. But resilience is really key to all of this. I've spent my career receiving lots of negative feedback. Bottom left-hand picture is me as an 18-year-old being told that I wouldn't amount to anything in my life. And even more recently, I've been told that I wasn't good enough for certain things. So I've had a career of being told, I regret to inform you. I'm sure some of you have had that as well, whether it's around a job, whether it's around a paper that I've written, or a grant or fellowship application that I've put in. It's a bit of a snakes and ladders that actually there's lots of those regret to inform you, but I try and look at them as opportunities to make things better. And actually, maybe they're right. Maybe the opportunity or the thing that I put in for wasn't the right place to put it, or it was the wrong job, or it was the wrong time, or I was just the wrong person for it. And that's okay. I can live with that. And I might be annoyed at the feedback they've given, and I probably swear quite a lot about it. And then I'll just go back and look at it and think, actually, they had a fair point there. Can I make it better? How can I make it better? And actually, I think I've used that as a sort of learning point throughout my career. But actually, all of these negatives come with all those ladders on the snakes and ladders game of things that I've managed to achieve or things that other people have supported me to achieve, because actually, again, this is all about the teamwork. So I think it's really important to reflect on all those downers when you think, oh God, I'm not good enough. Actually, you are good enough. And the person that's said you're not good enough is wrong. And actually, I'm a bit stubborn, as my family will tell you. And my PhD supervisor said I was tenacious, and he wasn't being particularly flattering when he said that. But actually, that's really important, because I went to a comprehensive school and most of my colleagues were privately educated. And I know that I've had to work hard to get where I am, and I am good enough, and I'm better than some of them. So that's really important, is don't let the bastards get you down. Apologies for swearing, but it's all been worth it in the end. But actually, you've got to be willing to learn and determined to learn, because if you're like that, no one can stop you. You're a force to be reckoned with, and actually drive that through in your career, whether it's clinical, whether it's academic, or whether it's in education. Really have that passion and that determination to improve, because actually ultimately we want to make things better for our patients. So it has all been worth it. So thanks for listening there. I've probably gone over my 10 minutes. I apologise.
That's absolutely fine. Thank you so much, Vicky. What an inspiring talk there, and just really, really helpful. Gives a really good overview of different journeys into the profession and all of the elements that need to be made up to kind of make you who you are today, and the skills and the knowledge that you bring to that. So thank you so much. Does anyone have any queries or any questions rather? If you want to put your hand up if you do, or if you want to put it in the chat bar, that's fine. I don't think I can see any hands. No? Okay. All right. Again, thank you, Vicky, for that hugely inspirational talk. I'm really grateful for you attending and doing that today. Thank you so much. Okay, so if everyone's ready, I'd like to move on to Jen Conquest. Jen, to give your talk if you're happy to do that and to share your slides now. Thank you, Vicky.
Thanks, Donna. I'll just try and share. And I'll just... Can everyone see the slides at the moment?
Yeah.
Yeah, okay. Hi, everyone. I'm Jen. I'm a speech and language therapist. I've taken on a new role in the last 6 months as a lead speech and language therapist for the IC rehabilitation team here in Derriford in Plymouth. One of my kind of main aims when I started the role was to develop a FEES service in the ICU. So that stands for fibre optic endoscopic evaluation of swallowing. So I'm just going to tell you a little bit about that today and why it's very important to have this set up for our patients in the ICU. So dysphagia is highly prevalent in the ICU patient population. The figures aren't exact, but anywhere between 20 to 83% of those that have been intubated for more than 48 hours are likely to have a dysphagia. 91% of those with critical illness neuromyopathy will have some level of dysphagia. 1/3 of tracheostomy patients aspirate, but majority of this will be silent aspiration. And laryngeal pathology is identified in approximately 58% of ICU patients who have a tracheostomy or have been ventilated. And again, there's a high proportion of those who will have silently aspirated. So dysphagia in the ITU is often multifactorial. It can be a direct result of the presenting condition of the patient, but it could also be due to previous existing medical conditions or as a direct impact of the interventions used in the ICU, and a lot of the time a combination of all of those issues. Another major impact in the ICU is disuse atrophy. So in awake, healthy people, we're swallowing approximately 500 to 700 times a day and up to 3 times an hour when we're asleep. In patients who have been sedated and ventilated, they're swallowing less than 100 times a day. So that's significantly reduced compared to what they would normally be doing, leading to, again, significant disuse atrophy of the muscles used for swallowing. So, sorry. There's been lots of work in recent years around looking at the management of dysphagia in ICU and within the speech and language therapy field of using FEES to help with this. So the National Confidential Inquiry for Patient Outcomes and Deaths in 2014 advocates for the involvement of speech and language therapists in patient management on the ICU for those with a tracheostomy and for access to FEES to help guide the recovery of these patients. Recent guidelines, 2022 guidelines for the provision of intensive care services, also state that FEES should be available to speech and language therapists to use for the assessment and management of dysphagia in ICU populations. So what do we look for when we're doing a FEES? What is the aim? So the aim is to observe upper airway patency. We're aiming to assess secretion management and level of secretions that patients have. We're looking at laryngeal sensation. We're looking at the use and the impact of one-way valves and cuff inflation and deflation on laryngeal sensation and secretion management. We're looking at overall vocal fold function and laryngeal function, looking at someone's ability to voice and communicate as well as their ability to swallow. We're looking for aspiration, particularly silent aspiration that isn't obvious through a bedside assessment. And we're looking at assessing patients to start oral intake as soon as possible. So I'm showing you some images here. So this is what we're looking at when we're doing a FEES. As a nase endoscope that is passed through the nose and sits just above the level of the pharynx and the larynx. We can see here these people have nasogastric tubes in, which is the yellow line here. Down here, you can't quite see it on this picture, but I'll show you here. We've got the vocal cords here. We've got the trachea down here. We've got the arytenoids and the epiglottis, all of which are used to help enclose the airway during swallowing. So these top two pictures demonstrate the impact one-way valve and cuff deflation can have on a person's sensation. So with no airflow through the upper airway in tracheostomized patients, they're likely to have a lot of secretions, as you can see here in this picture. They are sitting on top of the airway. So this person is aspirating their secretions. So they have no airflow to their upper airway. If we deflate the cuff of the tracheostomy tube and place the one-way valve on, then we get improved sensation. we get a clearer, more open airway, and the person is able to feel the secretions and able to swallow them. So this is demonstrating one of our aims of using FEES, and that's to kind of determine the impact of these treatments on patients. The other reason for using FEES is to assess someone's swallow. These two pictures show a patient who doesn't have a tracheostomy, but where FEES was used as a swallowing assessment. And these images, I was hoping, can kind of show silent aspiration. So you can see secretions here that are going to trickle down into the airway there, and this one's a little bit more obvious with a more solid bolus. So FEES is easily performed at bedside. It's associated with minimal complications. The equipment used is portable, allowing for equal access to all patients. And obviously the results are kind of timely, and we can immediately initiate interventions as a result of the findings. It's safe and effective diagnostic tool to use for weaning and decannulation in tracheostomy patients, along with assessing aspiration risk and swallowing ability. So the outcome of the FEES will contribute to the patient's weaning plan. It will help guide any secretion management techniques, such as looking at medication, suctioning, the weaning process of using one-way valves and cuff down to restore airflow to the upper airway, looking at starting oral diet as soon as possible, or if someone is not able to do that, then looking at alternative feeding requirements, potentially for the longer term. Looking at the management of laryngopharyngeal reflux, and also considering other onward referrals, whether that might be to ear, nose and throat teams, gastro teams, or for further assessments, perhaps such as a barium swallow or a video fluoroscopy. Helps guide us in the treatment of any laryngeal edema or laryngeal injuries that might have occurred during intubation, and will help guide tracheostomy tube management. So whether we need to consider using different sizing of tracheostomy tubes to allow further progress and rehab. And that's it. There we go. That's the end of my presentation. Thank you.
Thank you, Jen. That's absolutely fascinating. Really good to actually see what it physically looks like as well. I think there's been a few comments there. So really, really good. Does anyone have any questions for Jen at all?
I've got my hand up.
Ah, sorry, Vicky, I
Sorry.
didn't see you there.
That's okay. Sorry, my dog decided he wanted to join in as well. Thanks,
Fine.
Jen. That was really interesting. It's a long time since I've worked on intensive care. I like the idea that it's portable, and
Yeah.
I just wonder whether it's something that could be used out in the community. I mean, I'm thinking not just around old people, like people with motor neurone disease and other conditions, where actually having some sort of assessment out in the community would be really valuable. And I didn't know whether it was something that was as portable that he could go out in the community in the back of the car.
Theoretically, yes, it is. Yeah, you can get. There are various devices out there, but it's a nasendoscope that you'd see kind of similar to that of an ENT would use, and you can get an attachment that link to a portable tablet, which can be obviously kind of charged but then taken away.
Yeah.
I think you'd have to, the complications of it are very minimal.
Yeah.
But obviously there are some, so you'd have to factor in, that as well. Normally, it's speech and language therapy led, and normally would have a kind of, you'd need 2 trained people there to use it. But I know in other trusts it's used for inpatients, outpatient community clinics as well. So maybe not going out to people's homes, but certainly running clinics where people are able to come into the hospital.
That's great. Thank you.
And Matt, you had a question.
Yeah, thanks, Jen. That was really good and fascinating. And it follows on from what you and Vicky were just discussing, I think. But because it's an area I don't know a lot about, is this something that's quite unique to your practice, or is it actually quite commonplace? Like, I guess within Devon, as we're Devon AHPs today, is it done in the other sites, or is it an extended scope thing you've developed?
No, it's widely used throughout the UK. I think hospitals and services vary quite a bit, and their access to equipment, to training. It's certainly used at Torbay Hospital for inpatients and outpatient clinics. It's used within Derriford here on ICU and through some of the inpatient units as well, although the lack of equipment and kind of funding for equipment has always been a barrier to getting these kind of services up and running. So it is out there and it is used in lots of the big hospitals and smaller ones as well.
Okay, lovely, thank you. Does anyone else have any other questions for Jen at all? Don't think I can see any other hands up. Jen, thank you for that fascinating talk. Really appreciate that, and especially the visuals as well. It was really excellent to see. Thank you.
Thank you.
And now I think we're going to move on to Sam, if Sam is here. I don't know, so if Sam's not, I think we have a recording to share. I can't.
Can't see Sam. Do you want me to share the recording?
Yeah, I know he emailed a little while ago to say he was intending to, but he might be a little bit late. But yeah, we can start sharing the recording if that's okay with everyone.
Just let me know if you can't hear any sounds. It's always a bit of a pain sharing with sounds. So just let me know if you can't hear anything.
Thank you, Abby. I can't hear anything. I don't know if anyone else can.
I can, but that's not very helpful if you guys can't. So give me 2 seconds just to play around with it and see why it's not working. I think, to be fair, I think he said he'd be here at past, didn't he? So
he did, yeah.
I'll probably get it working just as he turns up. So.
That's fine. It's always the way.
Doesn't look promising when it comes up saying it can't share the sound, does it?
I know it's exceptionally busy across the piece today, so hopefully Sam will be able to join us. But I know the operational pressures for everyone
my
are
computer's just coming
extreme.
up saying it can't share the sound, which isn't very helpful.
Okay. I don't know, what are people's thoughts? Do we want to wait a few more minutes to see whether Sam arrives? So I think we're a bit early as well.
He said in the chat just after 12:30 he should be here.
Yeah. We'll give it a few more minutes. Sorry, did someone else? Matt, was that you that said something?
Yeah, I was just going to say, Abs, do you want to send it across to me and I'll see if I can share it with sound?
Just give me one more go at sharing it. I'll just try sharing it again because I've changed something that may work. So just let me know if you can't hear it.
Hello, good afternoon. My name is Sam Crompton. I'm urology
Can
specialist radiographer at Derriford Hospital. Sorry that I can't be with you this afternoon. I'm here to give you an introduction really about shockwave lithotripsy. So shockwave lithotripsy is a new service, or relatively new service, to the region, and certainly in the way that it runs. It's an outpatient procedure that's treating urinary stones in the kidneys and the ureters and uses shockwaves to fragment them. We started in August 2020. Prior to this, there was a private service that visited each trust on an individual basis, which had some drawbacks in that emergency patients couldn't be treated. Since we started, we've treated 700 stones successfully. Over 1,200 sessions of lithotripsy and 550 stones have already been successfully cleared. So what are shockwaves, you might be asking? So shockwaves are a longitudinal or sound wave that's got a very abrupt change in pressure. So this is sort of like a sonic boom, or quite commonly seen in munitions, and this picture here sort of demonstrates that quite nicely. So why do we do lithotripsy? And certainly in the way that we do it now, well, we got a lot of benefit from some recent reports. The first one from 2018, a Getting It Right First Time report. And this identified that many patients would have stents to try and protect their their kidneys before they went on to have treatment, which would often mean that they have to have 2 operations, and stents are particularly uncomfortable for patients. And this report sort of recommended that instead of doing 2 separate operations, it should just be go on and treat the stone. And one of the ways to do this is with access to acute shockwave lithotripsy, which is what the drawback of having a visiting mobile lithotripter was causing. So having a fixed site regionalized service would allow that rapid access to treatment. And then second piece of research that came out was NICE guidelines changing in 2019. And this put a lot more emphasis on lithotripsy than had previously been the case. So previously there had been a consideration for lithotripsy for all sizes of stones, but now at those lower than 10 millimeters, it's now offer rather than consider. It also put an emphasis on performing emergency treatment within 48 hours of diagnosis. And it found that the success rates of lithotripsy are somewhere between 72 and 84%. Another really important part of any of this is cost. So shockwave lithotripsy is found to be just under £2,500 more effective for stone-free rates compared to operative management, which, when you put the numbers that I gave you before, means that since we started just over 2 years, we've saved £1.3 million. So how do our patients get to us? Well, there are 2 different streams really. We've got emergency patients, and this is sort of the critical ones that we try to get right. These patients are going to turn up in A&E, and if you've ever seen a patient who's got renal colic with an obstructing stone, they're in an awful lot of pain. So they'll present to ED. They'll have a CT scan that confirms they've got a stone and that they're not infected. They get referred directly to lithotripsy from there, and we'll, if we're happy, go on and treat them ideally within 48 hours. Quite often manage to do it on the same day, patients walking down from ED or from SAU. Or elective patients, more incidental findings, but the pathway is sort of very, very similar. The only extra step is that they get reviewed by urology in the first instance before really too much is going on. So yeah, and then we go on and treat them. We treat at the moment 5 elective patients a day and 1 emergency, which at the end of the day, and the access is the same no matter where the patients present. So if they turn up at Derriford, or if they turned up at the RD&E or at Royal Cornwall hospitals, they've got exactly the same access to our services. What happens when they do get to us? So once they get to us, we have a clinical nurse specialist, or myself or one of our urology doctors will consent the patient, make sure that they're going to be safe to have it, that their medical history doesn't contra-intervene, and that there's no specialist treatment parameters that we have to use for patients such as those with pacemakers, cardiac history, single kidneys, and so on. We can perform the treatments localization with either X-ray or ultrasound. They have to be adequately coupled to the lithotripter. So a lot of people describe them as sitting in a little puddle of water. I prefer not to use those terms as such. But the water is really critical to whether this treatment is going to work or not. And we can treat up to 18 centimeters from the skin to the stone, which is actually quite a long way, and we haven't had many patients where that distance has become a problem. We've got some pictures here of the treatment in action. So on the left, you've got before or at the very start of the treatment, and then on the right, you might be able to see that the stone's starting to fragment off into the corners. So you can see just here that there's parts fragmenting off. And then further, we've got some lovely pictures here of a patient with some stones in their left kidney. You see that there's 2 stones there, and the upper one of the 2 is already fragmented into lots of different parts, and we're focusing there on the second lower stone. And hopefully what happens is that a couple of weeks later, patients will return with little bits of stone fragment for us that we can send off for analysis. So a really important part of what we do is then finding out what their stones are made of, and this allows us to give tailored advice for diet and things like this that will hopefully mean that they don't form any further stones in the future. That's almost more beneficial than being able to treat that one stone. Complications. So we do have a few complications that can occur. Hematoma is probably the most significant of those. So that's bleeding usually around the kidney, and that can be quite significant. Steinstrasse and obstructing fragments are similar sort of concepts. They're when you break the stone into little bits and then they fall down the ureter. When it's just one, you'd call it an obstructing fragment. When it's becoming multiple, it's called a Steinstrasse, and that's German there for stone street. So it looks like a whole bunch of cobbles coming back up the ureter, and you might be able to see that hit there in at the bottom of the image on the right there, on the right hand side of the patient. And sepsis as well is another complication that we can cause. So these are patients with infected stones that we weren't aware of before we started. As the stone fragments, the bacteria come out and cause the UTI, which obviously can then go on to be more significant. Outcomes. So how are we doing so far? As I say, about just over 2 years, we've got an success rate of around 80%, which, if you remember earlier from the NICE guidelines, we're sort of heading towards the upper end of their expected amounts. Our median treatments for elective patients 56 days, emergencies are 3 days, so we're a little bit further out than we'd like to be, and we are doing a bit of work to try and bring our emergency treatment from diagnosis to treatment time down by another day. And that's really about it. So if anyone has any questions, I've got my details on here, and I look forward to hearing from you.
That was great. I don't think Sam's been able to join us yet, has he? I can't see him on the invite list there, so unfortunately not available to ask any questions following on from that fascinating in presentation there, so thank you to Sam. Obviously Sam put his details on the end of the presentation there, so I'm sure he wouldn't mind if anyone had any questions to contact him directly following presentation. Abby, sorry, you've got your hand up.
Just going to be perhaps a little bit cheeky, and while we've got Vicky with us, I've just been sorry, not to put you on the spot too badly, but I'm just thinking over the last few days we've heard some amazing people presenting amazing projects, and kind of a lot of people have said, oh, it would make a really good research project, and I'm really interested in getting involved in research. And as the Southwest NIHR training lead, I wonder whether, Vicky, if you just might give some pointers as to where people might start. Sorry, that is a bit cheeky.
Yes. We've already done your appraisal recently. No, that's absolutely fine. So there are lots of opportunities for people to try and explore and get a taster for research. And the main one is around internships. So I think the internship programme is currently open at the moment, and I will put it in the chat in a second. So the internship programme is run jointly between Health Education England and NIHR, and it's run across the region. So it goes up as far as Gloucester and right across to Bournemouth. And basically these internship programmes are available. It covers up to £10,000, so covers some salary, but also some training and development costs. So for example, to do a master's module, to try and get some experience of getting involved in research, being linked to an academic department, and hopefully that will give you the taster then to go on to maybe go for a pre-doctoral fellowship. So we know that these internships work. So we've had a couple of people in the regional, I think Justine Tansley spoke yesterday, who's a podiatrist who's doing that. We've also got Kate Taylor, who's a dietitian, who came through the internship, currently doing a pre-doctoral award. So these are really great opportunities to actually get a taster in research and link with an academic department. So obviously in Devon you've got us in Exeter, and then also in Plymouth, and they're looking for some academic leadership that doesn't have to be in your profession, but it's someone with academic expertise that can maybe guide you and give you some experience of doing research. So at the moment, I'm supervising someone who's doing an internship who is a musculoskeletal physio. Which I'm definitely not, but actually we've got some common areas of interest around shared decision making. So actually she's going to spend some time with me, and she's learning about patient public involvement in research, etc. So there's lots of skills that can be shared around. I mentor Justine, who's linked down to Plymouth. So actually we work quite well together across the two universities. So there's some great opportunities out there if you think you've got a passion for research. And if you don't get it the first time, doesn't stop you from going back again. As I have said, I've had that opportunity myself, and I've gone back, thought about it, and then gone back again at another stage. So that's the good thing, is these opportunities are also open. And there's other opportunities. So the Clinical Research Network offer the associate programme to get some experience of doing research. We recently had an internship programme through PENARC, open to people from health and social care to actually apply, and we didn't get any AHPs apply at all, which was very sad, but actually we've appointed 3 nurses and someone from social care to take part of that. So great opportunities out there, and we can make sure maybe these opportunities really get filtered out through the forum. They usually go out through the Council for AHP Research Network. If you're not aware of that, it's something to link in with as well. Again, I'll pop it in the chat in a second. So yeah, tons of stuff to get involved with.
Thank you very much for answering that spontaneous question there, Vicky. That's really helpful. And welcome to Sam. So bless you, Sam. So despite your best efforts, as you put in the chat, you couldn't keep people on to time to attend, but I'm really grateful to you for recording your presentation so that we could listen through, and really useful, really good information in there. So I don't know, following on from Sam's presentation, and now he's here, if anyone's got any questions for him.
Hi, yeah, sorry, I did try. I tried my very best, but I'm sure you all know what consultants can be like.
100%. Okay.
Sam, I've got a question. Sorry, I was waiting to see if anyone else asked, but I didn't want it to be me every time. But my question was, how did you go about getting the service set up? Because it's such a great thing, but it seemed like on the last presentation, there's the thing about cost of equipment being a barrier and how that can be one of the things that other services may not use it. And obviously you'd had to address all of that in getting it set up. So I wondered how you went about doing that.
Yeah, it was a very long process, and the key part really to making setting our service up so effectively was getting the right people at the right time. So we had quite a large steering group that we met once a week over the course of about 2 years before we started. It was a huge multidisciplinary team, including people from finance. So getting that right really was what helped us work so well. Having the backup of the NICE guidelines and the Getting It Right First Time report helped massively as well. And then having the pressures on the operative treatments, so huge backlogs, and by proving that we were able to address that, can overcome some difficulties around funding. But it is certainly something that, I mean, we bought the most expensive equipment that was out there to buy for lithotripsy. So we had to make some quite strong arguments about why precisely this equipment would work best for a regional service, and that's ultimately what it came down to in the end for us. Because it was regionalised, there were some aspects of the more expensive equipment that allowed us to make a good argument to say why this would work best.
Thanks, that's great insights. Yeah, cheers.
That's okay.
Thank you, and I think good lessons there for all of us. I'm sure most AHPs are quite good at being persistent and chipping away in the background, and if we can demonstrate value and cost saving, all the better. So really, really good to hear that. So I think we have another question from Rebecca. So Rebecca, I'll hand to you.
Hi Sam, that was a great presentation. You cover the region, is that right? The whole of the southwest?
Yeah, that's absolutely right. So we cover all of Devon and Cornwall. We've actually had a referral from Taunton Hospital as well, but we're starting geographically. That's quite a long distance for patients to travel, but when it's an effective treatment, so that one patient we had, very large stone, we managed to treat her successfully on the first attempt, which obviously I can't plan for that, but that was a very good result. But that's the range at which we cover, yeah.
And is there demand enough to set up the service in other trusts in the southwest?
Probably not, and that's why the Getting It Right First Time report suggested that regionalised centres are more what should be worked towards. But I think given the geography of the region, there potentially could be an argument, but I don't think from our experience, the demand wouldn't be there for us to for other centres to have one. I don't think.
Thank you, Sam.
That's great.
Thank you. It was a great question. Any other questions at all for Sam? No? Okay, thank you so much, Sam. It was incredible timing there at the end so we could ask those questions of you. So thank you for attending. And thank you to everyone for sharing their presentation and for the chat and for questions today as well. Again, it's been absolutely fantastic to see the work across the area and to share all of those elements of success, but also perseverance. And as you were saying, Vicky, just kind of keeping going, even if you're told no, just keeping going with that's a really good message to take forward. So thank you for that. Does anyone have anything else, or Abby, is there anything else that we need to add in today before we close?
No, I don't think so. Just massive thanks to everyone presenting, and Donna, thank you massively for sharing. It's really appreciated. So thank you.
Thank you very much. Thank you, everybody, and I hope we all have a fantastic day tomorrow on AHP Day. Thank you. Bye.
Thanks all.
Thank you.
Bye.
Bye-bye.